an important graph to show the number of cases that are being reported per day. But you're right, context is everything here. Testing has changed beyond recognition. Back in, say, March, April, when there was a really relatively small number of tests available compared to now, when we're dealing with hundreds of thousands of people being tested a week. So it's absolutely not comparable. The age range of people being affected is not comparable, and that's reflected in the hospitalization data that we were talking about, and is partly why it's so very different.
But that's important. Obviously, in the Joint Biosecurity Centre, you're conveying information to the public, and people could see that the number of daily cases going up to the level that they were in April, but it's strictly non-comparable. It's right that that's the number of people that have tested positive that day, but far more tests, so it's not really, there is much less COVID around, one would infer, than there was in April. Is that right?
So alongside that, there is other data that is in the public domain, and that's why transparency is quite so important. Professor Heneghan mentioned the hospitalization data, which is updated every day. It's really important to take all of that information in the round, and that's one of the things we do daily across the public health system, is look at all of the different sources of data, local to national, and look for where there may be emerging hotspots, emerging things to be investigating, use some very sensitive models as well to try to understand if somewhere has changed quickly. The local teams, that's local health protection teams and local DSPH, know an awful lot about their areas and can investigate that. And then those areas that need to be escalated for discussion with the CMO or for discussion with the Secretary of State that can happen, but that's all part of the system.
Okay, back to Mark. Sorry to interrupt, Mark.
On the back of that, I mean, transparency, yes, but would you be concerned about transparency without the context? Because right now, my constituents are very anxious. The Manchester Evening News publishes a chart every day of Greater Manchester, and it's got two red arrows going that way for Bolton at the top of the pile. What would be your suggestions for making sure that we have the right context?
Who's that to, Mark?
I think, please.
Dr. Waite, yep.
I think having as much information available and presenting that all together is one of the really important things. We know, as we've talked about, that there are research studies such as the REACT study and ONS that give far more, they illustrate the bigger picture in addition to incidence, to positivity, to the number of people going into hospital, to the proportion of people who are symptomatic, the number of people who are taking up testing, and whether those people are being tested through the Pillar 1 system, through NHS, or whether they are symptomatic or asymptomatic people or contacts of people being tested through Pillar 2, for example. So the more information that's out there, the better, but it's absolutely right to be making sure that we're describing that in terms of the current context and not with how things were in March or April.
Thank you. Mark?
I think Professor Heneghan would like to come in.
Yeah, so there's been a fundamental shift in the debate away from protect the NHS and the impact of the disease to cases. And one of the key aspects is what you really want to know, and what we want to know, I suspect the people in Bolton, is to what extent this is impacting on the healthcare of the population. So one of the key aspects is having a clearly defined case definition of COVID and whether it's impacting in terms of care home, whether it's impacting in terms of admissions. And this is one of the key aspects, you see. If we're going to react and have restrictive measures, we should be expected to do them in terms of the impact of the disease. Just to say, in March, the RCGP surveillance data was reporting about 300 to 350 per 100,000 consultations symptomatic across the country. So you can get a level of where we were across for everything at that level. The question is, what's the impact in terms of disease in Bolton? Now, if that changes and there is an impact, healthcare is being consumed at the level where we say it's epidemic, hospital cases are rising, you'll get more trust and buying from the population of Bolton than you will do if you say we've got cases and about 80% of them are asymptomatic and we're not sure what's happening. Okay. And if you did that...
Professor Heneghan, can I just ask, because right now the Department of Health is saying that in France, hospitalizations have tripled, and last we're doing comparisons, looking at other countries. What would you say to that?
Okay, so if you look at the data in France and Spain, it's starting to flatline. It's not going exponential. It's gone to about 10,000 cases in France and Spain. Interestingly, in France, if you want to test, you have to get a prescription, so you have to come through clinical care. and you can only get a test if you have a prescription. Second is they have a different private incentivized system for hospitalizing, more hospital beds. Some of that may be appropriate, particularly for the very elderly in care homes. We may want to admit more people. That's an important aspect. But there's also an important aspect to consider about this disease as an endemic disease. If you lock down hard early, as France and Spain did, as they open up, there will be areas where there's very low immunity. That could be the case in Bolton, because that's why we're seeing it affecting different areas as we go through this epidemic, this pandemic, sorry.
Professor Heneghan, we're going to have to move on. If we keep answers short, then we'll get through more. Mark, I'm going to need to go to colleagues. Have you got any?
Yes, Chair. Sorry, just lastly, it's my colleague Chris Clarkson, who represents Haywood and Middleton, and his question was just with specific reference to areas such as Rochdale and Bolton, where additional restrictions are in place to combat rising infection rates. What baseline sample is considered scientifically robust for monitoring the change in rates? And with the current difficulties in providing tests, will this hamper efforts to monitor and control infections in areas with above average levels of infection? Just briefly, please. Thanks.
Dr. Waite?
Sorry, I missed the middle of the question, Chair.
So can you tell rigorously whether the incidence in Bolton and the other areas affected, whether that is dependable enough to act in the way that we are? Is it statistically robust?
I mean, absolutely. With the number of people who are coming forward for testing, the increasing trend in Bolton in the last couple of weeks is very different to anywhere else and is not matched by by a corresponding increase in the number of tests. Now, it's important that it's restricted to particular age groups, but across the country, linked to Professor Heneghan's point, we want to be absolutely clear that we want to prevent that spreading to older age groups or people who are more vulnerable. And we're seeing that in some countries, and including in the northwest, in some areas, including the northwest, we are seeing increases in hospitalizations, mercifully from a very low base, but we are seeing the beginning of that trend.
Thank you. So I think on that point, continuing the northwestern theme, we're going to go to Catherine Fletcher.
Thank you, Chair. I want to kind of maybe dive in a little bit into the work of the Joint Biosecurity Centre. You know, you're quite a new organisation, and I think if any of our less kind of biologically qualified constituents were listening, there's an awful lot of kind of bits of data and names and acronyms what's the word? When you have a series of letters to
acronyms.
Thank you very much. Don't love being dyslexic. Could you just tell us how it's set up, how you get all of that massive melange of data together, and how do you split kind of analysing the data with giving advice and the responses within your remit?
Thanks. So the JBC was set up as part of the rapid upscaling of the response to the coronavirus pandemic. And our aim, being part of NHS Test and Trace, is to help use that data, to analyse that data, present it, to try and identify COVID transmission chains, and thus to stop the spread of the virus. We're the analysis function within Test and Trace, but we're part of the Department of Health. And the idea behind JBC is to bring together experts from across government. There are so many epidemiologists, public health experts, and so on in the national public health agencies of the UK. And we bring in data analysis skills, data science skills, data infrastructure skills to pull all that information together in a systematic fashion to help inform both local decision making, but also the national decision making by the Secretary of State and so on. We do that by helping to identify outbreaks early, to assess whether or not there are things of concern by looking at hospitalization data alongside the Test and Trace data, for example, and looking at those risk factors, so age, ethnicity, location, and so on, by local areas or local regions. So there are and there will be outbreaks, and our role is to help pull all that information together.
Catherine?
So how are you actually pulling all of the different statistics in from Test and Trace and the ONS and the REACT? Is it all antigen testing results? Is it, you've also mentioned population demographics. Are you doing historic antibody prevalence surveys with the ONS? Is that going in? Could you just give us an idea of what's going into the pot to make future predictions?
So we're obviously, as you say, really quite new. So we aren't doing the sort of research studies that you mentioned there. Those are important, but we work with the teams that do. You mentioned the ONS study. There's also all of the surveillance studies that come in under Pillar 4 of test and trace, and the antibody testing and so on as part of Pillar 3. But we use the test and trace data, public health data, supporting information about environmental risk factors, population sizes, workplaces, geography, information that we get from, for example, the ONS. And then
so that's quite a list. Is it enough? Do you need anything else?
I think it's really important that we get as much new forms of data in to see if they are useful, to look at those in parallel with this data, use our data science experts and the data analytics platform that they're establishing for test and trace, and see what's useful. I mean, we're working with, for example, UK Research, UKRI and higher education institutes to look at whether or not there's information that's useful about transport, about understanding how people's behaviour changes around restrictions at local level or interventions at local level. Because trying to
we need to keep the answers short, I'm afraid, Dr. Waite.
So are you doing? Yeah, no, I could get a clear view of that. What I'm interested in is how all of these different data sources coming in, including behavioural, are allowing you to make future predictions and whether there's a gap. So, for example, we've heard evidence previously that there were multiple seeding events for when COVID-19 originally entered the UK. Are you looking back at how that happened to try and prevent it in future? You know, what is it that gives the British people confidence that you're not just sat in a room boiling the ocean with data and, you know, it's going to take you so long to come out with an answer that will have a vaccine? If I ask it a well-meaning question.
So you're absolutely right that there was evidence from CogUK, so from genomics data, about the number of seeding events back in March, April, and around half term then, which is when we saw a lot of introductions. No one wants to go back to that. That's one of the reasons that the international data that one part of our team looks at, and the information that we can use from other countries, is so important. So looking at estimated case rates, estimated prevalence, the number of travellers who are coming in, thus trying to look at the number of imported infections.
Dr. Waite, I'm sorry to stop you. That's another list of the data that you're using. How are you getting from that to making the predictions? And I can see Professor Richardson's been waving to come in, and anyone so august, I need to give you an opportunity.
Last question then, I think, Catherine.
Crash it down. How are you getting that to future predictions?
So it's not so much about future predictions as by describing what we know that's going on and trying to help inform strategies to prevent what may happen in the future. There are modelling experts that we work with, for example, the SPI-M groups, who have real expertise, real scientific expertise in producing those models, and we will use the data and ask them questions. They've been extremely supportive whenever we've asked questions, and I would expect to continue to do so.
Right, Professor Richardson.
Well, what I wanted to say is that the statistical community has been really hampered in their effort to tackle this question of integration, that the very pertinent question that you're asking about integration of all these data sources with all their different biases and their different characteristics, and not having access and not having a central core where, you know, all these data can be put together has been really hampering the intellectual effort of many people who really want to contribute. This is not an easy task, but it's a task which is doable if first, the community is engaged. In the community, for example, the Royal Statistical Society and the wide academic community.
So forgive me, just so I understand you. So you're saying that the Joint Biosecurity Centre at the moment is not that hub that you require?
Well, what I'm saying is there wasn't a hub like that, and I very much welcome the Joint Biosecurity Centre, which is creating that hub. So I think that's an extremely positive move, because at the moment, all the analysis that people have been scrambling to do have been difficult because of getting access to data and getting data in the one place. So it has limited our possibility.
Okay. Yeah, I hear you. Thank you.
Thank you very much indeed. Can we turn to Graham Stringer, please, our colleague?
The Biosecurity Centre is a much welcome development, and in particularly the fact that they want to engage with the academic community and with expertise to actually bring this difficult problem on the table of many brains.
Thank you, Professor. That's very clear and very helpful. Graham Stringer.
Professor Heneghan, going back to what you were saying before about the steady infection rate in Oldham, I think you said it was 60 to 70. What conclusions, what can we infer from that steady rate? Is it that the measures that have been introduced on behaviour are having little or no effect?
Yeah, I think what you can conclude when you start to think about endemic environments, you've got a test and trace programme that's having an impact. But one of the key problems is the government and policy keep intervening soon as that test and trace reports an upturn in cases. So that creates a confused policy. What's the purpose of the test and trace if all it leads to is lockdown measures? So somewhere, somebody is going to say, let's test out the test and trace programme. And in doing that, let's see what happens, looking at the impact of the disease in the hospital and see what happens in the terms of the cases. Now, there's an important issue you should be thinking through with the test and trace programme is a proportion of people infected but not infectious. And our work has showed if you start to use what's called a cycle threshold, look at the amount of virus on board for individuals, you can identify those who are at higher chance of being infectious, and that's the people you go after. But at the moment, because you can shed RNA for up to 3 months, despite having the infection for only 8 days, we are potentially following people who are red herrings. And what's happening in Oldham is, as you've seen for about 7 weeks, it's just grumbling on. And as you're doing that, your population is developing immunity. It will be harder in a place like Oldham because of the population, the unique issues with the ethnicity and the density. So
on that basis, you have been quite critical of the tests that are based on polymerase reaction, in effect giving us too many false positives. Is that a fair assessment of your criticism, and what do you think the response to that should be?
So look, the test is a very helpful test, but if you're just using a blanket policy without thinking through the strategy of what you use the test with what threshold, you end up with this problem of false positive. You are identifying too many people who could have had the infection in the past, and you're not picking up and allowing the 1 or 2 people who are what you've just described before, the super spreaders that you need to isolate and get to their contacts. So what we need now is, once we accept the infection is endemic, is a process where we start to develop our strategy around the testing. And a cycle threshold above 35 generally is people who are not infectious, yet NHS England documentation that has not been updated since January runs cycle thresholds to 45, which is identifying people who are not infectious.
Graham. We're running out of time. I'll try and squeeze my last 2 questions into one. There is a certain amount of criticism of the test there. I'm told there are 200 tests available worldwide for this virus. Have we got the best tests? And is work being done to get what would be the most appropriate tests in this country in the future? And the second question is really to follow up on the polymerase reaction question. Again, there has been criticism that repeat testing gives you far too many false positives in effect. What do you think we should do to counter that effect?
Who's that to, Graham?
To Professor Heneghan.
Yeah, so the first thing is, you're right, there are over 200 tests. Look, we do lead the way in science and development and technology and research. But the problem we've got right now is we've got more marketing than science based in the approach. You know, statements like moonshot are not helping us develop an analytical, accurate test. So that's the problem. What we have to do, and I'm happy to write because we're running out of time, is develop a strategy that uses a test in the most appropriate way so that we can have a sustainable use of this test now and over the long term. But the way it's being used now is inappropriate.
And the issue about repeat tests, Professor Heneghan?
So repeat tests can be very useful. You see, if you're asymptomatic and you repeat the test within about 3 to 5 days and the cycle threshold has gone up You're basically saying to somebody, you are not infectious and we can rule you out that you can carry on about your life. So we can be much more useful about them tests. If it goes down, that means your viral load has gone up and you are the person who is infectious. So there are ways uniquely of using the test that could develop as a much better strategy, and then we wouldn't have the lockdown. We'd be able to use a test and trace program much more efficiently.
Okay, thank you. Can we go to Carol Monaghan, please?
Thank you, Chair. If I could maybe follow on from that, last night on Channel 4 News, Professor Alan McNally was from Birmingham University, was talking about a different way of testing, and he was talking about the possibility of, for example, going into a school, testing at random, and if the random test showed that there was an incidence in the school, test everyone at that point so that you can actually pinpoint infections. As we're approaching the winter months, do we need to be looking more creatively about the way we are testing populations?
Who's that to, Carol?
Well, I was directing it towards Professor Heneghan to start with, just because he was talking about the way in which we're using tests.
Okay.
I wouldn't recommend an approach like that ever, because I just do not think what you're considering is that we're going to test our way out of this pandemic. In effect, you're saying random tests will pick up people potentially with dead virus. Remember, it picks up an RNA strand that's 20 nucleotides long. That degrades much slower than the actual infection when you've got it on board. After 8 days, we cannot isolate live virus. But up to 90 days, you can isolate the RNA fragments and pick them up when you test. So if you randomly go into schools, you might as well shut them down right now. And it's not a process that I recognize in 20 years of experience of being a clinician as a GP, or in a process that's aligned with evidence-based medicine. So if we're going to go down these routes, we have to think of the wider context of what harms does it introduce, what's the social consequences, and what's the plan. But I can tell you what's happening right now. When a single student, and I've just heard this today, in a year 13 class has a positive test, despite not knowing whether he's been infected or infectious, the whole year 13 has been sent home. So we've got restriction measures coming in now because nobody has a strategy or is thinking through how we use these tests appropriately.
Carol?
Thanks. I just see there's Dr. Waite and Professor Richardson.
Okay, Dr. Waite and then Professor Richardson on the same subject.
So, I mean, go on, Sylvia. Go on, Professor Richardson.
I just wanted to say that pool testing could be an efficient way of dealing with when there are groups of people, well-defined groups. Then it could be an efficient way of actually testing, because you could see whether there's a positive in the pool, and then you do other testing. I'm not commenting. I think Professor Heneghan has explained very well that the tests need to be better characterized in terms of transmission. And what I would like to put a recommendation for is that we use the test and trace captive population, which is told to isolate, to study further transmission, what is happening in these quarantine people, the contacts of the household. And this could be done by having add-on studies, which would visit and do some testing and have questionnaires. And then we would understand, including the cycle and then the strengths of the virus, we would understand much better transmission patterns, and then we could take policy decisions by transgenerational contacts or whatever. So I think transmission and using the test and trace population to add on transmission study would be an important component.
Thank you. Dr. Waite, and then perhaps a final one from Carol.
To agree with Professor Heneghan that I wouldn't agree with the proposal that was mentioned. Testing doesn't prevent you getting the disease. What's really important is that people who've got symptoms get a test, but that they also go home and self-isolate and prevent the opportunity to spread it on to others. And on the point about lab tests, there's been some advice published for guidance for labs on what to do about using CT cutoffs and so on. You have an expert I know coming up on a future panel on that, but there is a range of guidance out there on how best to use those tests.
Carol?
Are we dealing with it properly in terms of schools? I mean, Professor Heneghan's talking about a whole year 13 been sent home. And I know from personal experience there was a positive case in my kids' school, but actually although we were alerted to the positive case, kids were not sent home. Do we need clearer guidelines about what should instigate a test and the circumstances that have to be reached in order to have a quarantine or an isolation, for example, in a school environment?
Dr. Waite?
Well, it's a time of huge change, so I can understand the concern, but there is guidance exactly for that, exactly for various different scenarios of a case in schools, who would need to be sent home and who wouldn't. We're only a few weeks into the term, and I know it's different in different parts of the country about when term started, and a lot to get used to, but absolutely we've got to make sure that the guidance is followed, because the education of our children is really, really important.
Professor Heneghan?
Well, look, I think this comes down to, again, I'm going to repeat the strategy. If you want to suppress and eliminate the virus, you test in schools, you have one case and you send everybody home. If you accept we have an endemic seasonal pathogen and we want to promote education, we want to keep society functioning, you have to have a strategy that minimizes those risks. And what's happening at the moment is the language and the rhetoric is making people so fearful and terrorized that they're going beyond the guidance because they're so fearful of what's coming next. So there needs to be a dialing back of the rhetoric. There needs to be a thoughtful discussion now about what exactly is the government's strategy, because I don't understand it right now. And if you clear that up, then everything can flow from that. And I do say that actually maximization of education across universities and schools is imperative, and keeping our children in schools is important. But at the moment, it is utter chaos because of the 50% increase in other respiratory pathogens that mimic COVID in children is creating chaos.
Okay.
Thank
Carol,
you. I know we're short of time.
Thank you very much. And finally, back to Catherine for a quick supplementary.
Yes, thank you, professors and Dr. Waite. I think you've really landed on something vital, which is the role that science and technology has got to play in addressing this. So I was intrigued to see a completely new type of test being developed and showcased, where it isn't about PCR-based testing. It's about almost taking an electron microscopy picture of a total virus, for which was scientists, we can also agree, is much more likely to be an infectious agent than a string of RNA, and applying AI to it for rapid and speedy tests. These things are all under development, but perhaps could you comment on the likelihood of that happening? Because that solves a lot of the problems. And maybe Professor Heneghan, so this government strategy is to back our scientists and almost invest in the technology that really fixes the issue.
So look,
Professor Heneghan, just a couple of sentences if you could.
So what fixes the issue here is having a strategy around care homes. In fact, that's where 40% of the deaths...
Sorry, just because of the time, on PCR based, is that something that you've come across?
So it's going to be unlikely that we're going to get tests that are going to solve all of the problem unless we integrate it with a clinical and evidence-based approach going forward.
Professor Richardson, non-PCR based testing, is that a moonshot or is that not going to happen?
I think there's a lot of research on new technological development of tests, but they will need to be evaluated very scrupulously. And they will also, I totally agree with Professor Heneghan, they need to be used with a particular strategy in mind. So testing isn't going to solve the problem. What solves the problem is having an objective and then using the best testing strategy for that, given the current tests that we have at our disposal. And of course, there is a lot of research, so new things will come along, which will be more accurate. And of course, they're welcome. But I completely agree that, the strategy and the objective needs to be quite clear so that scientists and public health research can actually develop an integrated.
Sorry, I just want to give Dr. Waite the opportunity to come in.
Very finally, Catherine, Dr. Waite, very briefly, please.
I don't recognise the test you were describing, but rapid tests, both ones that could be undertaken in the lab and out in the community, could be real game changers for how people get their results. The really crucial thing is about how they're validated in the lab to understand their accuracy, because single decimal place changes for the accuracy of tests can make massive differences when tests are being used at scale.
Thank you very much indeed to our three witnesses. We could have gone on for much longer, which is an indication of the interest that we have and the expertise that we have had at our disposal. We may have some questions that we'll follow up in writing, but we're very grateful for your time today. I'm just going to suspend the meeting of the committee for a very brief moment so that we can invite the next witnesses to appear. Order, order.
There's a lot to fit in there, wasn't there?
Now, let's see who we got here.
It was very interesting.
Yeah.
We could do a kind of follow-up letter. Right. Can the witnesses hear me? I'm sure Baroness Harding can. Susan, Simon, can you hear me okay? Good. Thank you for coming. As you've seen in the previous session, it goes very quickly, and the shorter the answers, the less frenetic it gets. So if you wouldn't mind indulging us. I'm going to count down from 10, 9, 8, 7, 6, 5. Order, order. The committee is back in session. I'm very pleased to welcome to our second panel of witnesses, Dido Harding, Baroness Harding, who is the interim executive chair of the National Institute for Health Protection. Thank you for coming today. And her colleagues who are joining us virtually. We have Dr. Susan Hopkins, who is the chief medical advisor to NHS Test and Trace, and Simon Thompson, who is the managing director of the NHS Test and Trace app. Thank you very much indeed for joining us this afternoon. Perhaps I can start with a few questions for Baroness Harding. Starting with, what is the current capacity of the diagnostic testing system?
So as we stand today, the capacity for both NHS testing, which we call Pillar 1, and the National Testing Programme Pillar 2 stands at 242,817 tests.
Why has that not been
per day?
Why has that not been published since the 10th of September?
That is being published at 4 o'clock today, as I understand.
Why was the gap? They were published all through the summer, but mysteriously they stopped on the 10th of September.
We have worked really hard over the last 4 months since I arrived to make sure that we validate the data that we publish. So from time to time, we are double checking and making sure that as this organisation grows really fast and adds in new data feeds from new labs, we make sure that the data is accurate. That was the only reason for the pause.
Something went wrong that you had to put right?
No, it was simply a question of validating the data and making sure that we weren't putting data into the public domain that wasn't accurate.
It was all right.
Internally, the NHS used constrained and unconstrained capacity. Which capacity are you referring to?
This is total capacity. So if you'd like the split between the two, the NHS capacity, the Pillar 1, as of today is 82,817. That's for the UK. This is all 4 nations. And Pillar 2 is 160,000.
Okay, and they will be published every day now?
Yes.
Will they?
Yes.
Still not entirely clear why there was this period this week in which, for the first time, they were taken off without explanation.
Just simply a question of validating data. Remember how fast this is growing. So just for context, on Monday, the 7th of September, the total was 226,773. So we're adding new capacity all the time. We just need to make sure that the data feeds are accurate.
During the days of this week, has the total capacity gone up or gone down?
Yes. So on Monday the 14th, it is only, I think, Wednesday today. On Monday the 14th, we stood at 231,921. So we've added 10,000 capacity in the last 2 days.
That's increasing?
Yes.
Okay. Now, so what is the current level of demand for tests?
It's quite hard to give you an accurate figure of the level of demand because, it's clearly obvious there is significantly more demand than there is capacity today. So the best way we have of estimating the total demand at the moment is the number of people calling 119 and the number of visits to the website. But that's not going to be a completely accurate, it's a proxy.
You must make an estimate, I assume.
Well, we make an estimate, but the number of people calling 119 and visiting the website would be 3 to 4 times the number of tests that we currently have available. But there will be some double counting in that. People will call from their home line and then from their mobile.
If you're managing the system, you must have a view of what the real demand is and what the capacity is. What is your estimate? Leaving aside people having to call multiple times because they can't get through, strip that out. How many people want to test? Then we'll relate that to how many tests are available. I think,
it is multiples of the total test capacity we have today. Bearing in mind the question you asked, Chair, of what is the demand, the number of symptomatic people who should be coming forward for a test will be significantly lower than that. What we have got, and we know this from surveys in our testing sites, that up to 20-25% of people who've been coming forward for a test don't have any symptoms.
But when you say coming forward for a test, in order to register, you have to have symptoms, do you not? In order to be given a test place, if there were one available, you have to report one of the 3 symptoms.
We ask people to confirm that they have one of those symptoms.
So how do you know that 25% of people actually have registered for the test but have no symptoms?
Because we've been running some surveys outside of our testing site. So after you've registered and you've then turned up at the testing site, and we've asked people whether or not they do actually have symptoms. And we surveyed, so if I give you the details, 24,000 people at 25 regional and local testing sites between the 1st and the 4th of September. The Secretary of State referred to this earlier today, and this data will be published online. 27% of people said they were there because they'd been in contact with someone who had tested positive, but they didn't have symptoms themselves.
Okay. In order to be there and to have got to the test centre and to be allocated a test, they've had to declare that they've had symptoms. You're saying 27% of people lied?
Well, I completely understand why people are worried and scared and coming forward for tests.
That is what you're saying, that 27% of people lied about their symptoms.
No, I'm not. But our local testing sites, you don't need to make a booking. You can just walk up. So some people will just be walking up to get a test because they're worried, because a colleague or a family member has tested positive, and it's totally understandable.
They wouldn't be allocated a test. They'd be advised that they needed symptoms to have a test, would they not?
They ought to have symptoms.
So that's not a demand on the test. They're not using tests. They wouldn't have been given the tests in those circumstances.
Generally, if we have people walking up, having either booked a test or asking for one, are brilliant people who are manning the hundreds of testing sites across the country, don't want to push away people who are scared. But we do have a significant number of people who are coming forward for tests who don't have symptoms.
Why have we had this sudden increase in demand? I think you'd agree that there has been an increase in demand, I assume.
Yes, there has definitely been a substantial increase in demand. I think that Professor Heneghan and the previous witnesses in your earlier session referred to some of this, which is that it's an entirely human thing to be scared and worried and to then think that the answer is to get a test. And so, if I, again, give you some examples, a restaurant owner contacted me yesterday where one of their staff had tested positive, and they then asked all of the staff to go and get tested. Whereas actually, unless they had symptoms, they really didn't need to be tested.
That could happen at any time. There's no reason why September has seen this increase in demand.
I think we, again, as Professor Heneghan pointed to, I think with all of our children going back to school, we've seen a very marked increase in the number of young children coming forward to be tested. So a doubling of the number of children under 17 coming forward to be tested, and more than that in the ages of 5 to 9. And again, I think, as I say, I completely understand this. I've got children at school myself. The temptation is one of your children has a temperature, they need a test, but then the rest of the family gets tested as well.
We knew the children were going back to school in September, did we not? It didn't come as a surprise.
And we planned for a sizable increase in testing capacity. As I've just described, we've been adding testing capacity every day, every week, over the course of the last few weeks, in anticipation.
But not enough.
Well, plainly, as the
by a multiple factor, you said
as the Prime Minister said yesterday, plainly we don't have enough testing capacity today, and we are doing everything in our power to increase the testing capacity.
One of the reflections this committee has made, and our purpose in conducting these inquiries, is to learn lessons that can be useful for decisions further down the road. And in the early days of testing, lots of decisions had to be made very quickly, and it's understandable that not all of those were the right ones, and there's no particular blame that can always be attached to that. But we did establish, I think, a consensus that we ought to have anticipated the need for increased testing and to put that in place before the Secretary of State made his personal commitment to surge it during April. And so it's dispiriting to find that we're now in September in circumstances which are entirely predictable, that people are going back to school, people are going back to work, and we haven't had the right capacity put in place during the quieter times of, say, June, July and August. Why didn't that happen?
Well, actually, I don't think that's true. So at the end of May, we had 128,000 tests a day capacity. Today we have 242,000. So it's not been a quiet summer for NHS Test and Trace at all. We've doubled the size of our testing capacity, which is exactly what we committed to do. And we're on track to double it again to 500,000 tests a day by the end of October.
During the month of April, the Secretary of State increased testing from 1,000 a day to 100,000 a day, a 100-fold increase. What seems to be apparent is that you haven't prepared for the increase in demand that has transpired. It may have doubled, it may have increased, but it hasn't surged to the extent that was done before, and clearly ought to have been done for September. Why wasn't that the case?
Well, as I said, as the Prime Minister said yesterday, plainly we do need to expand testing capacity. And I really understand the frustration and worry that people have who are trying to come forward for tests.
Is there a problem with the assessment of demand? Are we going to be able to have accurate predictions or assessments of what demand will be in future?
But I just answered the previous question. So we built our testing capacity plans based on SAGE modelling. We published our business plan at the end of July, and we are absolutely on track to deliver that. So we're doing everything in our power to bring that forward, but we will have, and I would say that today we have more tests per 100,000 population than any other major country in Europe. We have in total tested more people per million population than any other country that has been hit badly by COVID other than Israel.
I do understand that, and so you've made a very important point. So the capacity that you have created has been the capacity that SAGE told you was needed at this stage.
Yes, we built our capacity plans based on SAGE modelling for what we should be preparing for the autumn.
That assessment was SAGE's rather than NHS Test and Trace?
Yes, indeed.
Okay. So the capacity is going to be increased to 500,000 a day, we understand from the Prime Minister.
Yes, that's correct. By the end of October, we will be able to offer 500,000 tests a day.
Will that be enough?
Well, I am certain that we will need more as we go beyond the end of October. And we announced this morning 2 further laboratories that will be opening, one in Newcastle, one in Berkshire. Those laboratories won't be on stream by the end of October. So we are already laying the foundations for expanding capacity beyond the 500,000 at the end of October.
You must have made an assessment, it would be necessary to make an assessment as to whether the 500,000, insofar as you can project it, have you set that because that's what you expect demand to be by the end of October?
We've set it as those were our plans, but as I said, Chair, it's clear from today that demand is significantly outstripping the capacity that we have. And so we are all going to need to work on this together. We do need to make sure that we protect the testing capacity we have for the people that most need it, which means that people who have symptoms are the people who should be coming forward to be tested.
Just in terms of that future demand and the future capacity, now we know from scientists on SAGE that the number of people in the population that display COVID-like symptoms during an ordinary winter, when COVID is not present, is 500,000 a day. So the capacity that you'll have by the end of October is only enough for the coughs and colds that people have normally. It actually doesn't address the extra demand that comes from a pandemic, and perhaps the extra concerns and sensitivity that people have, that they may notice symptoms more if they know that COVID is around.
Well, and as I said, we have plans to go beyond the 500,000 a day, and we announced openings of new labs today that will contribute to that. And our work on capacity building beyond the end of October is based on, again, clinical and scientific modelling of what the country should need in a winter season rather than a summer season.
I see. Go to Dawn and then to Mark.
Can I just come in on one vital point on this? How do you measure total capacity? Because the Prime Minister has said that there was a 375,000 capacity. You've now told the committee today that there's a 242,817 capacity. That seems to be a reduction in the capacity that the Prime Minister said. But how do you measure capacity, and do you need to revise how it is assessed?
The figures I've quoted you are antigen testing. The figures the Prime Minister was quoting are combined antigen and antibody testing. So they're completely consistent.
Right, so it's two different.
Clearly you didn't prepare enough for the schools coming back and people going back to work. The fact that the end of October was the target date to have this capacity in place, was that because you expected a second wave, as it's sometimes called, to be in October? Has it come earlier than you expected? Is that the problem?
Well, I think that I don't think anybody was expecting to see the really sizable increase in demand that we've seen over the course of the last few weeks. So none of the modelling was that expected. And that's why I say I think we all have to think really hard about how we prioritise the use of these tests. That we're clear that you should only get tested if you have the coronavirus symptoms, if you've got a fever, that you've got a new and persistent cough, or that you've lost your sense of taste and smell. And so we're all going to have to play our part in managing the constrained capacity, even as we double it and keep going beyond that.
That's been the guidance for months now. The rationing is within people that have symptoms, that certain people with symptoms won't be able to access it for the time being.
As I said, we see quite a lot of people coming forward who don't have symptoms, and I really understand why you would feel like this, who want to believe that if they get a test, they won't need to self-isolate, that if one of their family members has tested positive, that if they get a test, they won't have to isolate with them. And sadly, that isn't how the virus works, and it isn't the medical guidance.
If you strip that out, you still don't have enough capacity. The Secretary of State this morning said that people would need to be prioritised amongst those that have symptoms.
Yes, and we're very clear on our prioritisation. So firstly, we're prioritising support for NHS clinical care, NHS patients. So we test hospital patients, including all admissions. That's the number one priority. Well, our number two priority, and again, Professor Heneghan referred to this, is to protect those in care homes. This is the one group of people who we're testing who don't have symptoms. We know that the best way we can protect those of us, our loved ones living in our care homes, is to make sure that we regularly test care home workers and residents and all new admissions into care homes. So of our testing capacity, roughly 50% of our testing capacity goes towards NHS clinical care and testing in social care. And that's before we...
So hospital patients, social care, what's the next priority?
NHS staff, including GPs and pharmacists where possible. That's the third priority. And actually, sorry, I misquoted. Let me get that right. The three priorities of NHS patients, social care, and then NHS staff make up about 50% of the total testing capacity today. And then below that, once we move to testing the general public, community testing, we are prioritising additional testing capacity for outbreak areas. So we look to make more mobile testing units, to have more tests in local testing sites for areas with very high disease prevalence. And then finally, the broad general public, where we are looking now, given the very large demand, to prioritise within that key workers, particularly teachers.
Is there a hierarchy within key workers?
Well, as I say, we're just currently working on that. But as many people have said, prioritising education, and particularly teachers, so that schools can remain functioning, would be likely to be top of that list, though the work is still ongoing.
I'll turn to Mark Logan now, but just to be clear, so 50% of the capacity you expect to be taken up by NHS patients, NHS workers, social care workers.
As of today, that is 50%.
The remaining 50%, first of all, will go to outbreak areas. As of today, what proportion do you expect to be consumed by that?
Well, if I could answer the question slightly differently, on average, across the country, we are testing in each local authority at a level of roughly 100 people per 100,000. Mm-hmm. And in our outbreak areas, we are testing at roughly 2 to 3 times that level. That's the way we look at it.
That remaining 50%,
yeah.
What proportion of that 50% will be mopped up by the outbreak areas?
I haven't got that figure in my head. I'm really sorry, because the number of outbreak areas changes from day to day and week to week. So I can share that with the committee.
This evening when you get back,
I can share
let the committee know that, and therefore what the residual is for the other key workers.
And I should there is one other element of testing that runs underneath this, which again your previous witnesses mentioned, which is the programmes we have, the surveillance programmes we have, the research programmes to make sure that we understand the prevalence of the disease, the ONS and REACT surveys.
That's not useful in isolating and treating.
No, but it is using testing capacity, and it's important that it does.
Mark Logan.
Baroness Harding, I represent Bolton North East, which is at the epicentre of the pandemic and has been for the last 2 weeks. Testing isn't working in Bolton. How can we have confidence that what's been happening in Bolton will not be the case for the rest of the country?
Well, I appreciate the concern and worry about testing capacity everywhere, and particularly in areas like Bolton where the disease prevalence is so much higher. But yesterday we did 1,093 tests in Bolton. Over the last 7 days we've conducted 6,968 tests. The last 14 days, 13,179. And as I say, that's roughly 2 to 3 times more testing than we're doing on average in the country. So while I do understand that everyone wants to have the maximum number of tests available, we are doing our utmost to prioritise within that allocation of the general public testing in Bolton and in the other areas of higher prevalence.
But I can't say to my constituents that we're doing our utmost whenever, for example, the first mobile testing centre that was launched last weekend in Bromley Cross, my constituency, was full of errors. It didn't go to plan. Again, what are we doing to make sure this doesn't happen in other parts of the country?
Well, we are rolling out more and more testing capacity every day, and we're also broadening our distribution network every day. So, if you sort of step back and look at the scale of the testing platform that we've built, we are on track to have 500 different testing locations across the country by the end of October. And particularly in areas such as Bolton, we are deploying more mobile testing units and also opening more walk-in testing sites in our inner cities, making it easier for people to access testing. So that is all in the plan. We are accelerating every bit of it as fast as we possibly can. We are all working day and night, 7 days a week, to try and deliver the testing capacity that the country needs.
Mark?
But are you finding that these mobile testing units in other parts of the country, like what's happened in Bolton, have the same problems? So, for example, the testing centres have capacity to test one person every 5 minutes in Bolton. However, whenever they were first opened, we're only averaging 3 per hour.
Yes, the reason for that is that the constraint in our end-to-end testing system is in the processing in the laboratories. Actually, the footprint that we are building, the 500 different local testing sites across the country, will be able to scale up more and more as the processing capability grows. And we have to restrict the number of people who are taking tests in the testing sites so that there's no risk of those tests going out of date when they're processed in the labs. So I do understand how frustrating it feels that when you arrive in a testing site and it doesn't look like it's very busy and you can see it could do more, but the capacity constraint isn't in those testing sites, it's back in the lab. And it would be very dangerous to send too many samples back to the laboratory, have them not be processed and people not know what their results were. So that's why we have to restrict the demand where we all come to get tested.
My last question is just people from Bolton, they can't get a test. A lot of people can't. Have been contacting me both on social media and by email, but they're saying that those living outside Bolton can get a test in Bolton, or indeed if they put in a postcode for Wigan, for example, then they can get a test in Bolton eventually. What would you say to that? Should people just turn up as a walk-in service?
Well, we've been making changes and learning and improving with each passing week. And one of the things we've done over the last 10 days is to reduce the geography that you can book a test in advance. We make our local walk-in centres open for people to simply walk in for exactly the reason you're describing, to encourage the sort of local residents. And we'll continue to work with places such as Bolton to see how we can ring-fence more of the testing capacity to our most high-risk areas.
Thank you, Baroness Harding.
You're moving that capacity from places of comparatively low risk to high risk, I assume.
Yes, and that's done at a local authority level, at a regional level and at a national level. So we work very collaboratively with the local authorities and with the regional public health teams in Public Health England to deploy the mobile testing units based on prevalence and outbreaks.
Is it the case that you told the Chair of London Councils that there will be a 20% cut in London's testing capacity?
So the London testing capacity, just again some figures. Yesterday we tested just under 10,000 people in London. We're averaging circa 10,000 a day. And London's testing capacity, tests per 100,000 per week are slightly above the national average. And as a result, over the last few weeks, London has seen the absolute number of tests allocated come down, precisely because London has a lower prevalence than Bolton and other areas in the northwest and now in the northeast.
Is that 20% figure accurate?
I'm sorry, Chair, I don't have that with me.
Afterwards. Let's turn to Dawn and then Carol and then Graham.
Thank you, Chair. Thank you, Baroness Harding. I mean, it is quite ridiculous, isn't it, that there were no tests available in COVID hotspot zones. Out of the 10 top COVID-19 hotspots in England, there were no tests available, and people were sent, far away when they had testing centres on their doorstep. But my question to you is, how do you define the capacity? How do you work it out, the capacity?
Well, first, it's not that there are no tests available in our hotspots, quite the opposite. There are 2 to 3 times more people being tested in the areas of high prevalence than the national average.
That's not actually the experience of people who are living in areas that are on lockdown, for instance. I mean, LBC conducted investigation into that. So that's not actually the case. And also, as you mentioned, that the facts are that, I mean, out of the government's capacity of 375,000 that they say they have of tests, the actual number of people being tested has stalled at just 437,000 people a week. And that was at the start of this month. So that equates to just 62,000 tests a day. So when you take what you say is the capacity and how many people are actually being tested, why is there a problem with testing?
I'm afraid that's not true. Today, 207,000 people were tested. Yesterday, 213,000 people were tested. On the 14th of September, so Monday, 213,000. On the 7th of September, 170,000 people were tested. So I'm sorry, I don't know where your numbers come from, but these are the validated ONS-checked numbers of people who were tested.
Even on those numbers, it's still less than what you say you have as a capacity.
You will never run at exactly 100%. Actually, for a couple of days in the last week, our laboratories have run at over 100% capacity, which we're very concerned about, because these are large and complex end-to-end operations. So if you take our laboratory in Milton Keynes, it's processing over 30,000 tests a day. That's 30,000 packages that have a swab in it and your personal details that have to be physically unpacked, prepared, processed, put through the testing machine, logged back into your system.
Yeah, so we understand that, you know, the delay is with the lab and the testing. That is obviously quite clear, and it's quite clear that's why you're trying to delay people taking a test. Now, I know that there's a research institution that has lent some PCR machines. They're on loan to the end of the month, which I'm sure is included in your testing capacity. Do you have plans to extend the loans of these PCR machines? And if not, what will happen if those machines are taken back?
I'm afraid I don't know the specific example you're referring to, but if we look at our path from the 242,000 capacity that we have today through to 500,000 at the end of October, there are a large number of different elements that make up that path. Tests ready to go through the that will I'll get there in a sec, sorry. That will expand that testing capacity.
The chair will not let me ask my other
there
questions.
are a number of laboratories across the country that we are adding into the network. That's acquiring more testing capacity. And then, as I've said, some of the larger labs that we announced a month ago or two ago are also coming on stream. So there's a whole range. I can't speak to your specific example, but
any machines that are on loan, you will extend that loan so that you can continue to increase your
It's
capacity.
a mixture, because some of them might genuinely be needed by their universities, for example.
Can I ask you just about Randox, who won a £133 million testing contract unopposed at the start of the outbreak? They disposed of 12,401 used swabs in a single day on September the 2nd, and they also voided more than 35,000 used test kits since the start of August. The company has not denied charging the taxpayer for voided results. Can you confirm that the taxpayer has been charged by Randox for these voided tests?
You're referring to a couple of incidents that are still ongoing. So at this stage, I can't confirm or deny that. We are working through with Randox and with the MHRA to understand the root cause and what's actually happened.
Okay. I mean, just sticking with Randox for a minute, up to 750,000 unused coronavirus testing kits were, as we know, taken out of the system because of safety standards. What were those safety standards? What was wrong with them?
Well, as I said, that's an issue that is currently under investigation together with the MHRA.
Okay. And Randox employs the MP Owen Patterson on £500 an hour. Do we know what he does for Randox?
I'm afraid you'd have to ask Owen Patterson rather than me.
Okay. And just my last bit of questions, Chair. We're talking a lot about people taking tests who are symptomatic, but we know this is an asymptomatic disease and it spreads asymptomatically. And Professor Bell gave evidence to this committee, and he said that it is a largely asymptomatic disease, which means that you have to be careful about track, trace and isolate strategy that relies on symptoms because you will miss 70% of the people. How do you square that with the current strategy that you're employing?
That is exactly why our second testing priority is care homes. So we are running a very large asymptomatic testing programme where we test all care home workers in adult social care every week for exactly the reason that you describe, and why we place that actually as a higher priority than the general population symptomatic testing, because we've learnt from the last 9 months how this disease attacks the elderly and the most vulnerable in our society, and how it's really important that we protect them in a closed environment in care homes by ensuring the disease doesn't come in.
Instead of criticising people who maybe work in care homes who are going to get tests that are asymptomatic, we're going to start encouraging them.
I'm not criticising care home workers. I'm not criticising anyone at all. Care home workers receive tests once a week today and have done over the course of the summer, and we're very committed, the government's very committed to maintaining that care home asymptomatic programme for the reasons I've just said.
Thank you, Don. I'll turn to Carol, then Graham, then Aaron. But just to follow up on one of the answers you gave to Dawn. In terms of increasing the lab capacity, you're building these new lighthouse labs, you're making use of other labs in this country. Are you making use of overseas labs as well?
Yes, we have a number of other labs both in the UK and overseas that we would deem surge capacity labs that we can bring on faster, and we are doing some of that as well.
What would be the capacity of those overseas labs?
A relatively small proportion of the increase. You know, we're talking low order tens of thousands.
Thank you. Let's turn to Carol and then Graham. Carol Monaghan.
Thanks, Sharon. I was just wanting to follow that up with Baroness Harding. What is the ultimate target for lab capacity per day?
Well, 500,000 a day by the end of October, but we are not stopping there. We've already started committing to opening more labs and expanding capacity beyond that, but we don't have a formal target beyond 500,000 at this stage.
The figures you've quoted today in terms of daily tests are way below that. So, and you've talked about increases of tens of thousands. How are we getting to 500,000? I'm assuming we can't keep increasing by tens of thousands every single day. So how are we getting to 500,000?
So it won't be a completely linear journey of 10,000 a day, but what you will see is substantial increases every week between now and the end of October. And you'll see it from a variety of different programmes of work. So our existing labs, particularly our labs in Milton Keynes, in Alderley Park and in Glasgow, will be able to significantly increase their capacity as they implement these new robotic processing capabilities. The NHS, our NHS labs in NHS trusts across the country are also significantly increasing their capacity as they implement new technologies and new processes. We are adding in additional laboratories. So we announced a laboratory in Newport some 6-8 weeks ago. That will be coming on stream during October. And we're also adding an additional lab capacity from smaller labs across the country, across Public Health England and other universities. So it is a number of different initiatives that step by step very clearly take us to 500,000. And I would say that the testing team have hit every single one of their testing targets over the course of the last 6 months as they've grown this industry from 2,000 tests a day to over 240,000 today. So we're very confident that we will deliver on our 500,000 by the end of October.
Oh.
And what about the turnaround time? At the moment, there's a target of 24 to 48 hours. Will it still be that?
Yes, absolutely. Now, you are completely right that, and we have seen, in the spirit of openness, we have seen test results take slightly longer than usual over the last week or so, and the results that were published this morning, you can see that. So 64.7% of people who are tested face-to-face received their result the next day between the 3rd and the 9th of September. That is below our target of 85 to 90%. We have very consciously, in the last couple of weeks, when we've seen the very significant increase in demand, made use of every single day of the 7 days of lab capacity to try and maximise the total number of people that have been tested. And what that has meant is that for some people, the testing turnaround times have gone out a bit. As we bring on more capacity over the next week or two, I would expect some of that additional capacity to go not to more people being tested, but actually to seeing those turnaround times reduce. It's a balancing act that we monitor in every lab across the country several times a day to make sure that we are maximising the number of people tested and trying to keep to those turnaround times.
And in terms of the symptoms, we've already had a discussion of symptoms. If people have a symptom, they have to get tested or they should request a test. Surely we should be looking for 2 symptoms. If I have a dry cough, it doesn't mean I've got COVID.
Well, in this, I would refer to Dr. Susan Hopkins, who's on the panel, as we take the clinical advice from the CMO, Susan and her colleagues, as to which symptoms and in what way we should prioritise testing.
I'm happy to do that. Dr. Hopkins?
Thank you. So we review the symptoms regularly and have reviewed the symptoms at least every couple of weeks since the start of this pandemic. Our most recent review a couple of weeks ago, again, looked at the 3 symptoms and cough, fever and the change in smell and taste were the 3 priorities. That will give us a rough sensitivity of about 80 to 85%. It won't pick up everyone, but it also gives a specificity of about 55%, which means that we're not testing anyone with one small symptom, but we're focusing on the people most likely to have the disease. We don't give a dry cough, a wet cough. We talk about it being a continuous cough. And the reason for that is that the cough can change over this course of the illness. And what we want to do is make something that was simple to communicate to the public. It still feels the right symptoms, and we've looked at both the Zoe app and other information coming out of ONS, React, and what they're finding on their surveys. And we feel like we've got the right sweet point for testing at the moment. We will continue to review that.
And it's still the advice, with one symptom you get tested?
It is, and we looked at combinations of those symptoms, but that reduces the number of people who would be eligible and significantly would reduce the number of people who are the right people to get tested in the community. It would drop down our sensitivity markedly.
Okay, thank you, Chair.
Thank you. Just on the timing, it is the case that the Prime Minister promised in June that there'd be 100% turnaround within 24 hours. Isn't that the case, Baroness Harding?
Well, we have delivered next day turnaround times in the 80s to 90% through the summer. And as I've said, it has dropped down over the last couple of weeks. And that was a conscious decision in order to try and meet more of the demand. And I would expect to see the turnaround times improve as we increase capacity over the next few weeks.
Of the home testing kits, the figure is 9% turned around in that case within 48 hours, and 1 in 5, 20% within 24 hours at local test sites. So very substantially below the target that was set.
So the 64.7% of next day turnaround I'm referring to is people who've taken a test in person. So whether they've come to a mobile testing site, a local testing site, or a walk-in site. You're absolutely right. The turnaround times for home testing kits have always been longer because the test has to make its way from your home. It's a slower delivery turnaround.
A test is a test. The purpose of the test is to contact trace and to inform where the infection is spreading.
And it is exactly why we've been opening more and more testing sites so that fewer people have to rely on a home test if they're feeling ill. The home tests are particularly useful for patients going into the NHS to get a test in advance of having an operation, where you're testing not to see if you have the disease, but make sure that you don't have it.
You're moving away from home tests as being...
Well, if you look at the mix, because we've opened so many more local testing sites and mobile testing sites, the mix is shifting to more physical face-to-face testing.
Is it a policy decision to prefer?
Yes, because the turnaround time will always be faster.
Earlier in the pandemic, in evidence of this committee, witnesses from Public Health England and indeed ministers talked very positively about the mass mailing of home tests as being a way in which you could improve the level of testing.
I think that at that point in the pandemic, as you say, when the testing platform was going from only 1,000 or 2,000 a day to 100,000 over the course of a very small number of weeks, it was entirely appropriate to be doing that. And home testing has a really important role in the overall testing platform. But if you've got symptoms and you're in the general population and you want to get a test result back straight as fast as you can, it will be faster if you go to one of our face-to-face testing sites, which is why we're opening so many of them.
Thank you. Graham Stringham.
I don't envy anybody who's got a senior position during this epidemic, but would you like to tell us how you became the acting executive chair of this new National Institute for Health Protection?
Of course. I didn't apply to do the job I'm doing at the moment. I was asked to serve by ministers. And I suspect, like everybody working on the COVID response, I felt it was the appropriate thing to do to serve my country and say yes to that request.
Do you think it's right, I know you've accepted the position, that you should accept a position without open competition, even though it's an interim job? it encompasses 3 previous agencies. It's a very important position. Don't you think there should have been competition? Because there has been a lot of criticism that your experience at Talk and in retail, which may have been fine in those areas, is not appropriate for this position.
Let's take a couple of things in that. So firstly, as you rightly say, this is an interim position and an unpaid position. And we've started the open competition to recruit the permanent appointment. And so given that it's important that there is immediate leadership, regardless of whether it was me or not, making an interim appointment without open competition is the way to ensure you've got leadership immediately. So that's the process, not my decision at all. Ministers chose to take that process. In terms of the skills that you need to do the job, well, the skills that the team need, and this is a huge team effort, is clinical, scientific, operational. This is an enormous consumer citizen service with huge logistics and data analytics and data flow. And I've got an amazing team of people, and I'm not for a moment going to pretend I've got all of those skills. Of course I haven't. This is a team effort. None of us like talking about ourselves, but my experience is and all my working life is in large consumer-facing services. And I've got a lot of experience of retail and logistics, and I've spent the last 3 years as the chair of NHS Improvement. So while I am not a clinician and only have 3 years' experience, I do understand the NHS and the public sector to couple with my logistics, retail and technology experience.
With your previous experience in this area and the month you've spent as acting executive chair, what do you think this new body will do better than was done by the previous 3 agencies?
And just so I understand, sorry to clarify, by the 3 agencies you mean?
Public Health England, the Biosecurity Centre, and what was the other one that's been put into it? I've not got it.
NHS Test and Trace. Okay.
NHS,
so NHS Test and Trace and the Joint Biosecurity have been one entity since they both began. So that was the reason for just wanted to clarify. So the immediate benefits that we are already seeing is accelerating the collaboration and joint working. So the 3 organisations were working very well together. But it's been actually rather extraordinary to see how in the space of a few weeks, by knowing that our long-term future is together, it's encouraging professionals in the clinical, the scientific, the data analytics, the operational teams simply to work together faster. And in the fight against COVID, those small benefits in team working and problem solving can actually make a very big difference.
How would we measure that?
You'll measure that's a very good question. I think you'll measure that by our ability to act faster over a broader landscape. So, for example, I was today at the meeting, the Gold local outbreak management meeting chaired by the Secretary of State, which is a hugely collaborative process between the Test and Trace team, the Joint Biosecurity Centre and Public Health England. And in the course of the last 3 weeks, objectively, we have seen much broader coverage of the country, much more work done collaboratively, and a much clearer local voice because of the integration with Public Health England. So I appreciate that's not an output measure, but 3 weeks in, I probably couldn't give you an output measure, but we are seeing a much more integrated, and Dr. Susan Hopkins on this panel is a great example. Susan is a joint appointment into both organisations and is leading our clinical and medical team in the fight against COVID in the National Institute.
Can you just explain to me, because I'm genuinely not sure, what the relationship of the new body is to the Lighthouse laboratories? Do you determine the contracts that are let out to the Lighthouse laboratories? Do you determine their policy? Do you determine their day-to-day work? What is the relationship?
So the Lighthouse laboratories are contracted by NHS Test and Trace, so by the Institute.
You let the contract.
And we work very closely with those partners as they are increasingly implementing new technologies in order to speed up and expand capacity.
When Serco's contract was renewed over the summer, had they met all their key performance indicators?
There was a full and comprehensive review of the performance of all of our contact tracing suppliers, of which Serco is one. And the recontracting process was led by our commercial teams in normal government processes.
That doesn't quite answer the question, if you don't mind me saying.
I'm sorry, I don't actually have all of the KPIs in my head, and I'm very happy to write to you to set out.
I wasn't asking you to have them in your head. I just wondered if they'd met all of them.
I can't. The nature of good commercial management is you set your commercial partners a large number of challenging targets, and so the only reason I'm hesitating is that they might have hit 99% of them, and then I wouldn't be giving you a truthful answer. So that was all. But they have done a good job. They stood up a service very fast. And as we haven't talked about contact tracing at all, we have reached 350,000. Actually, no, sorry, it's now, from the numbers published this morning, 417,000 people, thanks to them and NHS professionals and local public health teams.
And what part of these contracts are public? I mean, you say that you will let us know what the assessment was. What level of detail will we get about these very significant contracts from the public sector to the private sector?
I will need to go back with my commercial colleagues and make sure that I share what is appropriate to share publicly, given that these are commercial arrangements. But obviously we would need to do that in full, normal, transparent process.
And if I may, I know I've had a lot. If I may have one last question. My view that some of the things that have gone wrong with test and trace and the whole response to COVID is that it has been too centralised, and that these lighthouse laboratories have over-competed to the detriment of many of the private and local NHS laboratories. What would be your response to that point?
I think that what we're trying to build is a local and a national system, and we need both. So the NHS and smaller university labs have done magnificent work in scaling up testing. Our local public health teams, both in local government and in Public Health England, have also done magnificent work. We need both. And so the model that we're trying to build is a local by default, but also a nationally supported. So we couldn't put on 250,000 tests a day extra capacity in the next 6 weeks entirely through the NHS. But the NHS is playing a huge part in that. Likewise, we couldn't have contacted 417,000 people in the last 4 months entirely through local action. We need both the national and the local. And what we're seeing increasingly, and particularly in areas like Bolton, Oldham, Leicester, Blackburn, real collaboration between local leadership teams and the national test and trace and joint biosecurity teams working together.
But nevertheless, the mobile laboratories were handed over to G4S, not to local authorities.
Well, if you mean the mobile testing sites?
Yes.
In order to be able to move them so that we have some flexibility.
We do want to come on to tracing and to contact tracing and indeed the app, but just to return briefly to the question of the turnaround of tests. The target that you're given by the Prime Minister is a 24-hour one, the 24-hour turnaround. The figures that you quoted to us were next day. So would you kind of give us what the performance of the system has been in the most recent figures within the 24-hour period against which you're measured?
It's quite a lot lower. I'm afraid I don't have the figure in front of me. The reason I don't is that a 24-hour turnaround time would mean we'd be measuring whether people get their texts and emails in the middle of the night. So from an I'm just giving you the operational statistics that we measure and focus on have been the next day. Simply because that's a way of ensuring that people get that test in order to be able to go to work or go back to school.
Well, it's the figure is 33%.
Yes, as I said, I know it's significantly low.
2/3 don't meet the target of 24 hours, and the reason that's relevant. Firstly, it's the figure that governs your work. It's the figure that was given by the Prime Minister. It was in your report that was published this morning. But it's also the case that this is not a it's not a random number. SAGE has been very clear. Right back at the 1st of May, SAGE said that any delay beyond 48 to 72 hours before the isolation of contacts results in a significant impact on the R number. And obviously there is a chain there. So if you have a delay in getting a test, and then there is a delay in getting the results of the test, and then the time that it takes to trace those contracts, the smaller and smaller proportion of people who test positively and are symptomatic have their contacts being tested. In other words, according to SAGE, it drives an increase in the R number. So isn't it the case that the failure of the testing regime, which I hope is temporary, is driving the increase in the pandemic across the country?
I strongly refute that the system is failing. So, as I said earlier, we made a conscious decision because of the huge increase in demand to extend the turnaround times in order to process more tests over the course of the last couple of weeks. And whether or not you get your test results at 2 in the morning or at 8 in the morning, actually our judgment, and it is a judgment, was that it was better to meet more of the people who were really worried and scared and wanted a test. We flex that across each channel and each laboratory, as I said, several times a day, 7 days a week. And as we bring on more capacity, I would expect those turnaround times to go down. But that is a balance. And the whole system is an end-to-end balance that is about us playing our part in expanding testing capacity, but it's also about all of us playing our part in only coming forward for tests if we have symptoms.
The committee has recognised and has called for the expansion of testing, and we're very supportive of the surge that took place in the spring. And so we recognise the efforts that have been made. So when I refer to the failure, it is the current failure, which it seems to me, if 2/3 of people are not getting their test results in line with the target, that is something that needs to be addressed. And let me put it this way. If SAGE say that you need to have the contacts traced by 72 hours, should you have a measure as to how that is being adhered to, given that your organisation that has been formed now is responsible for the whole pathway, if you like, from testing people to identifying contacts? Should that 72-hour target, so as not to increase the prevalence of the disease, should that not be what you're judged against?
Well, we're judged by quite a lot of metrics, and we try to be as open and transparent as possible and publish all of them, as you know, each week. So we measure not just the turnaround time for testing, but we also measure and report on how fast we reach contacts. And we measure the percentage of contacts that we reach. So SAGE set us a number of other targets as well. They set us a target to reach 80% of people who had tested positive, and we reached last week 79.8% of those. We also set a target to reach 80% of contacts, and we reached 86.6% of contacts where we had the communication details of the people who were named as contacts. So you are absolutely right that end-to-end turnaround time is also important, but so is whether or not we keep everybody flowing through. So all of this is about balancing each of those different operational measures.
Let's go into that a bit more with Aaron Bell.
Thank you, Chair, and you've anticipated some of my questions there nicely. Thank you for your time, Baroness Harding. I did want to turn to tracing. We've focused a lot on testing, and rightly so. You just gave us some of the statistics. Taking it all in all, from the top, the people who were transferred to you in the first place, what percentage of their contacts overall, once you go through all the stages of contacting them, trying to contact them again where they're complex, what proportion of contacts overall do you estimate you're reaching? Not the ones that you're trying to, at each stage, but overall, what percentage of contacts do you estimate you're reaching from positive tests?
Well, it's hard to do that because we've got to estimate how many people our index cases have actually told us about. And so I'm hoping we're going to get a chance to talk a little bit about the app, because one of the big gaps in our measurement is people that you've been a close contact with who you don't know. Because index cases can only tell you, people who've tested positive can only tell you of the people they know. Whereas if you're an app user, that should significantly improve our effectiveness. So it's hard to actually answer your question because of that unknown.
But of the known contacts, I mean, if you're not reaching around, is it 17% of people in the first place, and a number of them you're not reaching their contacts because they haven't got the details or whatever? You know, does it end up being more like 50% than 80%? Is that a known contact?
I might defer to Susan on this, just because this is very standard for contact tracing. It's a well tried and tested public health intervention for a whole range of infectious diseases. And while you're right that it's a percentage on a percentage on a percentage, that is how you break the chains of transmission.
Yes, of course.
And you're never going to get 100% at each stage. I don't know if Susan would like to.
No, I appreciate
it more. Will I come in briefly? So I think it's really important to recognise that in an ideal world, when an individual recognised they were positive, they would be able to know exactly who they had been in contact with in the previous time that they were potentially transmitting infection. What we know is that people who are coming forward, we're getting about 85% of people who come forward for contact tracing. The others don't answer their phones, don't answer emails. So there's very little we can do for those. In some local authorities, they started door knocking, where we've got postcodes for those individuals, but we'll never get 100%. Secondly, when they give your contact details, they can only, sometimes they may have the wrong phone number for an individual, they may not have the correct name, and we'll do everything we can to try and find those, again, including door knocking, where they can give addresses in local authorities who have initiated local contact tracing. But actually, all of this brings the sort of app into sharp focus, because what the app does is it doesn't matter whether you know someone's details, it's giving you an estimate about whether you've been in contact with someone, and being able to tell that other individual whether they're at risk and what they should do next. And I think Simon might be able to clear up exactly what the app is doing.
Okay, we'll talk about the app in a little moment. If I could just go back to Baroness Harding then. We obviously, you reach a certain proportion of people, and you obviously ask a number of them to self-isolate. What do you then do? Is that the end of the line as far as the tracing app is concerned, or do you monitor whether people do self-isolate, Baroness Harding?
So we have been conducting some trials over the summer to understand how people cope with self-isolation, because it is really hard for a number of different reasons. So understanding what support makes a difference, what the triggers are that mean that people might not stick to it. We've been running a number of different tests of calling people or sending them text messages, and also making sure that they've got support from local government. And what we've learned over the summer is that it is actually very hard, and that most people try their best to do the right thing, but that they either have caring responsibilities, or they feel they need to pop out to grab something from a shop, or they just want some fresh air, and that a meaningful percentage of people find it hard to stick to that self-isolation during the full 14 days.
So you're saying that a large percentage don't stick to it completely. Are there some that disregard it altogether, as far as you're aware?
I don't have hard data for that. I'm afraid, but I think it's safe to assume that across an average there will be some people who don't, and that we need to really impress upon people that the way that we all get back to a more normal way of life is that if we are very high risk of being infectious, if we've been in close contact with somebody who tested positive, that we do follow the advice of NHS Test and Trace and we self-isolate.
And what proportion of the people you ask to self-isolate go on to develop COVID?
I don't have a statistic for that. And one of the reasons I don't is we don't test people who are in self-isolation, and we don't test them for two reasons, or we actively don't want them to come forward for testing for two reasons. The first is the nervousness that if you test negative at some point in your 14 days, that will be another reason to believe that you'd be okay to go back to normal life. Whereas, as I'm sure Susan can talk us through, unfortunately the virus doesn't work that way. So we don't test during self-isolation, and as we've described earlier, that wouldn't be one of our priority uses of testing. So I'm not able to give you quantitative data, though again my clinical colleague Susan may have more evidence than I.
Sure, but I understand the logic of what you've just said in terms of the impact on the individual, but from a scientific perspective, isn't it worth knowing whether self-isolation is actually keeping COVID cases out of general circulation?
Maybe if I could refer the question to Susan.
Okay, yes, please.
So I think what we know in looking at the case details is that the people who you're most likely to transmit to are your household contacts. And the next groups are those that you're in close contact with. We do look and try and match data from contact tracing to the testing records, but we don't find very many people who come forward for a test. But that may be due to the fact that many people have asymptomatic infection, and we've asked them to self-isolate for 14 days to prevent transmission to others.
Thank you, Dr. Hopkins. I mean, Baroness Harding, you understand where I'm coming from a scientific perspective here. The Royal Statistics Society has recommended improvements to this data, including random sampling, record linkage. Have you looked at taking those recommendations on board?
We are continually looking to improve our service, and remember how new this is. This scale test and trace service that is only 5 months old, and absolutely we are looking at continuing to understand how we improve our ability to break the chains of infection. And again, I'm sure Susan can talk to some of the research work that we are doing with academics and statistical partners across the country.
Thank you. I mean, it seems you acknowledge yourself, and I acknowledge that it's hard for people to self-isolate. And if we're aware that the most obvious ones who need to self-isolate are immediate family, it seems that only fair and a sensible way to approach a pandemic that we're having to manage, we're not trying to completely eradicate, that we assess whether the kind of people we're asking to self-isolate, whether that's actually doing any good. And unless we have that information about whether those people ever had COVID, it seems we're not going to refine the system. Would you agree with that?
I think, as Susan has said, there are two things about this virus that are incredibly counterintuitive to a layman like me. The first thing is that it's counterintuitive to believe that you're most likely to catch the disease from your friends and family. It's instinctive to believe that strangers are more dangerous than the people that you live with, and yet all the evidence is your household contacts are likely to be the most likely people that you will either infect or get infected by. The other thing that is counterintuitive is a belief, we all want to believe that a test will set us free, that if we test negative, then everything's fine. And yet the way the disease incubates, that's just not true. A negative test on day 2 or 3 or 4 or 5 or 6 of self-isolation doesn't mean that you won't infect your friends and family at some point during the 14 days. And so we do know those two things. And Susan can give you the academic foundations. We do know that our intuition is not how the disease works. And if we are going to break the chains of infection and we are going to get back to a more normal way of life, we do need to follow the clinical guidance.
Thank you, Baroness Harding. I'll pass back to the chair. We're short of time.
Thank you, Erin. I'm grateful for that. I'm going to invite the Minister, Lord Bethell, to join us to have some questions on the contact tracing app, as well as Baroness Harding on this. Just before we turn to that, obviously we've been talking a lot about the increasing capacity that's targeted in the 500,000 a day by the end of October. Minister, is that all antigen testing, or does that include antibody testing as well?
No, the 500,000 is for the test and trace programme on antigen testing.
Pure antigen testing. So this is what helps people detect whether they've got the virus in order to be isolated and have their contacts traced. Thank you. I'm very grateful. On the contact tracing app, so Minister, I think next week you're planning to launch or to relaunch the app. It was trialled on the. You didn't launch it nationally. You now feel confident that it's going to be in a position to work?
Yeah, no, I am incredibly confident. I'm going to ask Simon to say a few words if you don't mind. And I have the app on my phone, and I've been using it for the last 3 weeks, and it's very impressive. And I've actually brought with me a copy of the QR code from my office. So if you had the app on your phone, you could check in at my office when you came and had a cup of tea with me. And that would then tell your phone where you had been at that precise point, and will play an incredibly important part in the contact tracing process. And one of the really encouraging things about the trials is that businesses really have stepped forward in the areas where we've been trialling it downloaded the QR codes and have been pinning them up. And getting the downloads of the QR codes is going to be an essential part of the success of the app.
Just before I turn to my colleagues Dawn and then Aaron, just describe very quickly what the main features of the app are.
I could do, Chair, but it would be, if I might suggest, that Simon would be a better person to do that.
Right. Simon.
So thank you, Lord Bethell, and thank you, Mr. Chair, as well. In terms of the app, there are some key features which are really designed to do two things. The first one is we call them a set of me features, which is helping the citizens manage their own individual risk. We have a capability called Alert, which means that it will give you an awareness and a warning of what it is that's going around your post-district area. So that's the first thing. And that means that as you leave your house, you understand what it is that you should do based on the advice, the medical advice that we have. The second thing it has, which Lord Bethell touched on, is a system that we call check-in. And with the check-in system, by using the QR code, it means that if for any reason there was an outbreak in an area where you'd been, we would be able to get in touch with you by getting a message to that device. We have some benefits that we call we benefits as well, which is where we can try and manage or help the user manage the risk of others. We have a symptoms checker, which by using a very, very simple questionnaire, it will let you know whether you are okay or whether you may well have the coronavirus. You can book a test online through the app as well. And also it has an isolation companion, which I think we've talked about a little bit on this call here, which is based on the advice that we have, the app will be there as your companion to let you know how long you need to isolate for. Maybe it's 10 days, 9, 8, 7, 6, 5, 4, 3, 2, 1. And then a situation where it could say that you are, as long as you don't have any symptoms, you are free to go back to doing what you were doing before. In addition to that, it is also a contact tracing app, which means that for people that have this app on their devices, it is seeing how close you've been to somebody and for how long. And if somebody should be tested positive, and only if they're tested positive for coronavirus, it would then notify you if you had been a high-risk contact. So that in essence is how it is that the device works. We have those benefits, those me benefits of alert and check-in, what we call the we benefits of symptoms test and an isolation companion, and it is also fundamentally a contact tracing app.
Thank you. That's very clear and helpful. I'll turn to my colleagues, but just to be absolutely clear, people, I assume, are not obliged to download the app. It's a voluntary service.
That's correct.
Yes, that's correct. It is indeed voluntary, yes.
And if it tells you that you've been in proximity to someone that has tested positive, and it tells you that you should self-isolate pending having a test, are you obliged to follow that instruction, or is it advisory?
Well, what we would say is if the app notifies you to self-isolate, then you are at risk, and you should follow the advice provided. And as I said earlier on, the app will only notify you if you've been near to an individual.
It's more for the Minister, perhaps.
No, we haven't mandated it in law, but the compliance by the public is something that relies on their confidence that it works. And so we are impressed by the public's adherence and are relying on that for the moment.
And so in terms of the sensitivity, does it detect proximity to someone at 2 meters for 15 minutes? Is that, have I understood correctly, the threshold of exposure that that triggers an alert?
Yes, it's triggered based on the medical advice. So 2 meters, around about 2 meters for around about 15 minutes.
If someone has tested positive and your phone detects that you've been in less than 2 meters proximity for more than 15 minutes, you will get an alert. Is that right?
That's right. You'll only be alerted if somebody has been tested positive and you have been close to them for a significant period of time within a date range that the app is monitoring.
And how can it tell that there hasn't been, for example, a kind of perspex screen between you and the person? Sometimes if you're in shops and things, there are screens installed. So you might have been very, physically proximate, but with a barrier there. Can it detect that?
Well, what we say is that within the front of the device, and based on a lot of the feedback we've had, and the use case that you've mentioned has been mentioned to us several times, is we allow you to switch off the contact tracing by a simple press of the button on the front under 3 conditions. The first one is perhaps you are wearing PPE. The second one is that perhaps you are working behind a Perspex screen, as you have highlighted. And the third one, which is another use case that we've seen, is that people might be leaving their device in a locker when it is that they're going off to work. So they are the 3 cases where we would recommend that you switch the contact tracing off. And we've done it on the front of the device, so it's super clear. The other thing that we learned from the trials, which we didn't have on the device at the start of the trials, is that when it's switched off, people have asked, could you please give us a reminder to switch it back on? This is why the trials are so important. So again, if you switch it off, it will ask the user, when would you like to be prompted to switch it back on again, so it's there as a notification and a reminder. But that is how we are handling the use cases that you've articulated.
Dawn.
Thank you, Chair. Lord Bishop, when the government first announced the £11 million for a centralised app, there was many people, programmers, etc., who were very clear that a centralised app wouldn't work because it wouldn't have the buy-in from the public to download. It was clunky and cumbersome, and no other country had a centralised app. What app are we currently talking about now, just for people who are tuning in?
Well, you are right that the early stages of our app development, we learned a huge amount doing it. There was a lot of comment at the time that we needed to take a different approach, and we learned from that, and we have taken a different approach. And this is a decentralized app of the kind that you allude to, and there are benefits to that. One principal benefit is consumer confidence. The consumer can rightly believe that their data is secure on the device, that it's very heavily protected, and that they can carry this app in the full confidence that it is fully private and held by them and them alone.
Did you think we needed to spend £11 million to get to that conclusion?
I think that there were really good reasons for going down that route. They were mainly epidemiological. The benefits of going down the centralised route is that we got a lot of data, and it was at a time when we didn't have any data at all. We now have REACT and ONS. We have a phenomenal amount of epidemiological insight every week coming in our surveys, so we know a lot more about the spread of the disease. Earlier in the year, we were flying completely blind, and therefore the emphasis on getting that data in was much, much stronger. Now that we have that other data, it is less of a priority.
Okay, thank you. What has the uptake been on the app?
That one I will refer to Simon Townsend for. Simon, would you like to take that one?
Yeah, we've been very, very encouraged. I think that, we did 3 areas that we did some testing in. We went to the Isle of Wight, we went to NHS volunteers up and down the country, and also to Newham. I think for those people that may well not know, particularly the Isle of Wight and Newham, they are a very, very different reality in terms of the population and how they move and their age and their demographics. So we were really keen to see that. What I would say is that having visited both of the areas very, very recently and spoke to the local team that have done awesome support in terms of helping us out here, is that, the adoption has been very encouraging. I think Isle of Wight in particular, on the grounds that it was the second time that we went back to the Isle of Wight, I think it was fair to say, and I looked from my own perspective, that we thought, well, let's see if people are happy to go a second time around. And actually, they were. They were very happy to do that. And in terms of Newham as well, by working with the local authorities who did a super job, again, we've learned many things there in terms of how it is we can encourage uptake. But I think the overall message is we should definitely be encouraged based on our learnings, both in the Isle of Wight and in Newham and in NHS volunteers. And I'll say it again, there are differences between Newham and the Isle of Wight, and the adoption has been very encouraging and the learnings have been invaluable.
Thank you. Are you going to publish the assessments of the Newham and Isle of Wight
Yes, we've always said that all of our evaluations will be published. We always said that it would be as soon as practical after our launch, and we are planning to launch next week.
Okay, great, thank you. And just, Chair, if I may, just very quickly to Baroness Harding, I hope this is helpful with Graham's earlier question, just to say that the government's flagship NHS test and trace system missed its key targets 9 weeks running, and Serco obviously missed its targets, and it was quite a surprise to people that they actually had their contract renewed, because they were paid 192 million to provide 18,500 call handlers and local authorities. And it's another case actually of the government trying to have a centralised approach as opposed to a decentralised approach, which would have been more effective. But I hope that's helpful.
Do you want to briefly respond, Baroness Harding?
Very briefly, we have a local and a national approach rather than a centralised one. We've doubled the number of people working in local health protection teams over the last 4 months, and we are continuing to recruit and expand. We work hugely closely with the Public Health England health protection teams as part of an integrated tracing system, which does have national, of course, the temptation to describe them as national. Actually, these are people working in their homes, in their kitchens, in their studies, calling people who are at risk of infecting their loved ones. And Serco and Cytel and NHS professionals who together stood up the national contact tracing, stood that service up in the space of 3 weeks, and have, as I said earlier, between now and then contributed to us contacting over 400,000 people. So I don't think that is a failing service at all. That's something that's delivered on exactly what it said it would do.
Thank you very much indeed. Let's go to Aaron Bell, then Carol Monaghan. Aaron.
Thank you, Chair. Lord Bethell, just briefly on the app, is it fair to say that the original goal of a centralised app which would give us lots more information, that's now completely dead?
The old approach has been changed to a decentralised app, that is true, but a lot of the learnings are still in place. And one of the original ambitions was to combine various different elements, from booking a test to the Bluetooth contact tracing to the various risk assessments. And one of the things I'm particularly pleased about is the way in which the app team have combined several functions in one platform, bringing a really broad user experience to people. And I think it's going to play a key role in our efforts.
Thank you, Lord Bethell. Just briefly, Northern Ireland and Scotland have got there ahead of us in England, based on the same technology, and I understand doing roughly the same thing with contact tracing. Why has there been a delay in getting the app out for England and Wales?
Well, I don't know if there has been a delay. We've moved quickly in order to get the app that we need right. I celebrate the fact that others have got their own versions. We will learn from each other. Interoperability is critical. We've worked really closely with the DAs to make sure that we can get the apps to work together. And in time, interoperability with other countries will be important when we come to the point that borders will be reopened and risk assessment between countries becomes really important.
Thank you. What assessment have you made of the Scottish data so far?
That is something I'd like to ask Simon Thompson to answer, if that's okay.
Sure.
Yeah, I mean, what I would say is that it's early days for the launch in Scotland. We do actually speak on a regular basis because we do share learnings. I'm really mad keen to catch up with the team and see what their assessment is of progress. But I think that everything that I've seen so far, I think they should be optimistic. And I think that, it's great for us. As you said, they're using the same base technology. I think it's great to see the team there have the confidence that we have in the technology as well.
Thank you very much, both. Chair.
Thank you very much indeed. Carol.
Thanks, Chair. Simon, can I ask you about the trials in the Isle of Wight and Newham? What was the percentage uptake in terms of the population?
Yeah, I mean, this is information that we'll definitely share within our evaluation that I said we'll do after the launch and as soon as is practical. What I would say is that based on the international uptakes that you'll have read, where everyone goes between sort of 10% and 30%, I would say that based on the results that we've seen, we should feel optimistic about what we can do. But, you know, it's similar to what we've always said, the more people that use the app, the better. I think the thing that we've really focused on, which Lord Bethell touched on earlier on, is making sure that the citizens have really confidence that it works and that it's actually bringing them, you know, a real benefit. And based on the trials that we've seen, we believe that that will be the reaction that we get. So
you're not able to give a percentage uptake?
No, we definitely will as part of our evaluation that I said earlier on. As soon as it's practical, we'll definitely publish.
So at the moment in Scotland, the app was launched about a week ago, and there's been an uptake of about 1 million, which is about 20% of the population. It's already given 100 alerts. But it should be noted that level of trust in Nicola Sturgeon is probably a lot higher than level of trust, certainly from what has been seen in social media regarding the app's potential launch in England. How important is trust? You've talked about, you know, the levels of confidence amongst the population. How important will trust be that this app is going to do what it says and is not going to infringe on data, people's personal data? Mm-hmm.
Well, you know, we are using the same technology as Team Scotland in terms of underlying technology. So now you are. I wonder. I'm trying to really tease out whether that information is getting out there, or whether there is still mistrust amongst the public in terms of this idea of the app. And
might I give some information? Just because, although the English app doesn't launch until Thursday, the QR code system is live, so that businesses are today getting ready for it. And we've seen sort of up to 15,000 organisations download QR codes already. So actually, I think we've got real evidence in England before our app launches that businesses are getting ready and really accepting it, so that when people, and that's something that is different from the Scottish app. We use the same contact tracing capability, but we've integrated the QR code system as well. So it's very early days, as Simon says, and I think both of the nations should be really encouraged that our collaboration looks like it's going to deliver another tool in the toolkit in the fight against COVID.
Maybe then, Baroness Harding, final question, Chair. Is there going to be some big launch with these questions that are being asked by people about their personal data? Is that going to take place? Because it did take place in Scotland, and I think that was part of the reason why people felt confident to download the app onto their phone. So are these big messages going to get out? Because there has been a change in terms of what the app will do.
Yes, absolutely. And I don't know, Simon, if you want to talk to it, because I actually completely agree that reassuring people that the data stays on their phone is a very important element of it. And we've certainly seen that in the trials in Newham, in the Isle of Wight, and with NHS responders.
Yeah, I think Dido, I think the point that's raised is an absolutely excellent point, and what you've said is absolutely true. Is we realise that trust is important, but based, as you've said, Dido, based on the results that we've had, we should feel confident about that.
Thank you, Chair. Carol. The distance criterion in the app is 2 metres for 15 minutes. The WHO advice is it should be 1 metre for 15 minutes. Why have we chosen a different metric, Minister?
We have assessed it a lot of different ways. There is a balance that needs to be struck between getting the positives right and the negatives right. We can't have an app that throws off so many false positives that trust is undermined. The app won't, in all of these epidemiological efforts, you're trying to have something that is both effective and trusted. And we think that the balance of 15 minutes and 2 metres strikes the right point in that balance.
Interesting, perhaps, if you could write to the committee with the evaluation of why you rejected the WHO's advice that it should just be 1 metre for 15 minutes, and you've gone for one that will capture more people. But
I'd be glad to, and I would also like to add that these things can be reviewed, and as we learn more and more about the app, it may be that we seek to tweak that as we go along.
Thank you. Finally, on the app to Graham Stringer.
No, fine.
Is that okay? Well, in which case we will draw sums on that. Very grateful to our witnesses on that. If we say goodbye to our online witnesses, and thank you for their testimony, and we've covered a lot of ground on other matters, but since we've got Baroness Harding and Lord Bethell with us. Perhaps we could just take a couple of minutes to reflect on some things perhaps relating to the ministerial oversight of NHS test and trace. Perhaps starting, Minister, with the question of the testing strategy and who is responsible for it. When the committee had its last session before the summer, it was with the Secretary of State, and he was very clear that the testing strategy is not something that is set by the NHS England, not something that was set by Public Health England at the time. It was set by ministers. So would you just summarise, give a kind of concise view as to what the strategy on testing is now as we approach the autumn and the winter?
Well, the thing I would probably reflect on is that the strategy remains with ministers, but there is a much broader collaboration across Whitehall. There is much greater involvement in a variety of different departments. When it comes, for instance, to the international element of test and trace, the DFT is much more involved. Cabinet Office provides an enormous amount of insight, and we work very closely with Downing Street in all matters. And in terms of the priorities, the watchword, the mission, is to break the chain of transmission, and that's how all of our metrics are ultimately focused. Is we're trying to stop the spread of the disease, and we have to weigh that up with also trying to return people's lives back to something that appears, akin to normal, and to get the economy restarted. So it is striking a balance between the most effective measures possible to use diagnostics and isolation to make interventions that break the spread of the disease, but at the same time release people as much as possible to do the things that they love and to lead productive lives. And so that would be the strategic balance that we are trying to strike.
And after we've got over, as we hope we will, the problems that are besetting the testing system now, and the capacity catches up with the demand, do you aim to be able to get back to what we were starting to be able to do during the summer, which is to make tests available to asymptomatic people more generally?
Yes, I think, the work that Dido has largely focused on is dealing with the technology that is not only provable and workable today, but is also industrially available and applicable. And those things are really important because we have to deliver speedy, accurate, affordable tests every day of the week. But there is on the horizon incredibly exciting developments. And having been involved in testing now for 6 months, I've been astonished by the rate of improvement in testing. Now, using our existing base technology, that has been largely about automation and the use of data in order to accelerate the speed and the turnaround of tests and to be able to put machines together and make them work at speed. But there are new technologies coming in, technologies that use different ways of measuring the virus, ways of using saliva or even breath tests, tests that at this stage are largely bench-based and innovative and not unproven in the clinical trial, but offer a huge amount of promise. And we are really focused in a parallel stream to try and support those innovative tests to give a completely different level of diagnostic.
That's the moonshot, isn't it? That's the what the Prime Minister describes as the moonshot.
That's the moonshot.
That's part of the strategy.
Yes, and I am the Minister of Innovation, and I have a spreadsheet of dozens of companies from all around the world who have got remarkable propositions that are moving incredibly quickly from conceptual to applicable to industrial.
And is the 10 million a day target, is that the target in the strategy?
Chair, I have to admit, I don't know exactly where the 10 million came from. That's not something that I am familiar with. But listen, in order to enable the return of the population to a life that is economically productive and where schools and colleges can be confident of going back, there is the potential for having massively more tests.
The 10 million is not something that you recognise?
It's not something I recognise, no.
Okay. Fine, and perhaps just a quick question to Baroness Harding, and I'll turn to Graham Stringer. What you said earlier, Baroness Harding, was very interesting in that you responded to the assessment of demand that was given to you by the modellers in SAGE. and it's turned out to be an underestimate. Given your current interim responsibility for the programme, and we recognise the voluntary public service that you're giving to that and all the pressures that comes with, and given your wide experience of the commercial world, will you be making your own assessment within NHS Test and Trace of what the demand is likely to be in the future, or will you continue to rely on the modelling estimates that have turned out to be so wrong?
We continue to work with a wide range of experts, and that is what SAGE and SPI-M, our modelling colleagues, and SPI-B for behavioural science, and they in turn draw very widely. I think Dr. Waite described it in the first session, that it's very important when you're looking at modelling to have multiple teams doing the work and then to compare, because the one thing you know about any model is it is highly unlikely to be precisely right. And what you want to do is take a number of different teams and assess and evaluate. And that's exactly what we are doing and will continue to do.
Graham String.
Yes, I've got a series of questions here that are very similar to the ones that were asked to Baroness Harding earlier, Minister. So we're short of time. I won't repeat them. Is there anything that Baroness Harding said about capacity and testing capacity and demand for that capacity and the reporting of the number of tests that are conducted compared to the capacity? Is there anything you disagreed with?
I think the only thing that Baroness Harding didn't say that I would have loved her to say is she expressed very clearly the frustration and regret that the demand is currently above capacity. But what she didn't express was, it was the pride that I have in how far we've come so quickly. And it's a difficult time to be saying this, because obviously a lot of people in the country are very frustrated and rightly very angry. But there is a bit of me that is genuinely enormously impressed by the way in which British business, British academia, the NHS and government have moved so quickly to stand up an incredibly impressive testing outfit. And it seems a shame to me that this session might go without that being said.
That's fair enough for you to say that, but it does leave the door open to me to ask what's the biggest mistake that's been made.
That's always a very difficult question, Graham. I think, listen, we have made plenty of mistakes along the way. I think that where we are sitting right now, we have to be really clear with people about the way in which this infection works and the way it harbours in the body, because there is a temptation to believe that having a test somehow is a cure, or if not a cure, is a way out of your commitment to isolate. And the Test and Trace programme really only is effective if people do isolate if they have tested positive for a test or if they've been in contact with people who have tested positive. And trying to convey that message is very challenging, and getting that right is something that we still have a lot of work to do on.
I agree with you, Minister. Clarity of message is absolutely vital in getting public buy-in to sort of protecting people's public health. Absolutely vital. I think ministers have muddied the waters on a number of occasions by not being clear or obfuscating, I think we can say. Just take an example over the last few days in terms of the distance people have been asked to go for testing centres. The Secretary of State and the Prime Minister gave the mean for the distance travel. Well, you don't have to be a statistician to know that the mode and the medium would be statistically give you a better idea of what was going on and how many people hadn't gone. So do you take that point that it might be easy for a minister to push the details on one side so they don't have to say we've got this wrong? Don't you think it would be better on a simple case like that if people were statistically honest and gave the median a mode as well as the mean and how many people actually hadn't travelled because it was too bloody far?
Well, listen. I am in favour of statistical candour, but earlier today we published a huge amount of statistics. We run an incredibly transparent...
No member of the public is going to read that. They may see the Prime Minister on the television. They may see the Secretary of State on the television or listening to him. They're not going to read that, Minister.
Well, listen, when it comes to the public, I completely understand the public's frustration. I have friends, family, and I can see what's going on. People are extremely frustrated. But when it comes to the statistics, we really couldn't be more transparent than we are. And I would just remind everyone that there will be more than 1 million people who have a test this week. And most of them, the vast majority of them, will have a benign experience around it.
My final question, if I may. You were here for the earlier session with Professor Heneghan, who I think was, in a very thoughtful and academic way, casting doubt on the change rules in the North East and Oldham and Bolton in particular. Could you give me your initial thoughts on what he said?
I think he spoke very interestingly about the difference between having a trace of infection and being wildly infectious. And that is something that we are aware of, the difference between the two. But everything that the clinicians tell me is that you have to be very, very careful about trying to create false differences between the two, because one person might have a small amount of infection today and a large amount of infection tomorrow. And if you try to create big differences between the two, you may store up problems for yourself in the future.
Thank you, Graham. Final question from Dawn, and then Erin, and then we will adjourn.
Thank you both very much for today. In July, the Secretary of State for Health and Social Care told this committee that reform of Public Health England was not a priority, and that he was focused on preparing for the winter, which, as we've heard today, is vital and important. However, less than a month later, PHE was replaced by this new National Institute for Health Protection. Minister, what changed?
Well, I think what the Secretary of State said earlier is right, that change for change's sake is not our interest. But Baroness Harding has explained, I think, really clearly how the operational benefits of getting these three teams working closely together has yielded massive results. And we did have a quiet point in August when we could mend the roof while the sun shone, as it were. And I think it was the right decision. It was a tough and courageous decision, but the right decision to try and grab those operational benefits while we could. And I work really closely with all those three teams, and I can tell you that those teams are working much better together, and that it is an enormously collaborative atmosphere, and those benefits are coming through. So I think it was a wise decision and the right one.
What changed? Like, did he not have those thoughts before? What changed in those 4 weeks that...
No, I think that, I mean, to answer you directly, what changed was an assessment of what the benefits of those operational dividends would be became clearer and more apparent.
It's helped the capacity chase that you're now in rather than hindered it.
Absolutely.
This change from PHE.
Absolutely.
Okay, thank you. Aaron Bell.
Thank you, Chair. Just briefly on overall strategy, Lord Bethell. To what extent is our current overall strategy and what you set out to the Chair about mass testing ideas and all that, is this predicated on hanging on for a vaccine? To put it another way, if we didn't think there would be a vaccine in the next 6 months and we thought there might be more like 2 years, would we be doing things differently?
Well, actually, that's a very good question. In some ways, listen, I'm extremely hopeful and optimistic about the vaccine. If you speak to Kate Bingham running through the options, you'll be really inspired at the pace of scientific change and how far we've got to go. But everyone knows who has spoken to the virologists that doing vaccines for coronaviruses, and particularly ones with a respiratory affection, is really tough and they don't always work. So we have to cover our bases. And I think that one of the things that we're doing with Test and Trace is to create something that is a fallback plan if the vaccine and the therapeutic drugs don't come through as we hope to. And if they don't, then we have an amazing infrastructure that can lean in really heavily into the disease and enable the return of both the economy and of the important bits of our normal lives, like the return to schools and universities. So we are hedging our bets, and one of the reasons why we're investing so heavily in test and trace is to make sure that we have that backup plan. I would also add that there is a long-term benefit here, which is a reboot in the national approach to diagnostics generally, and putting diagnostics at the heart of our overall life sciences strategy of early intervention in disease. And I'd be glad to talk about that either now or later.
Thank you, Lord Bethell. And just one specific point before we have to wrap up. Just on quarantine, SAGE has advised that repeat testing could be a way of shortening the quarantine period. Is the government considering this approach? And if so, how will it be implemented and when?
Sure. Well, we are working really closely with DFT colleagues, with airlines, with airports, and I would love to see the reopening of borders when we can. But the CMO is really clear. The borders have, we've already had very tough outcomes from people coming into the country bringing disease with them, and we have to rely on people complying with quarantine, and the evidence suggests that that's a very difficult thing to rely upon. So until we have a truly reliable, affordable, and proven system of quarantine, we have to be really cautious about taking on any new responsibilities in that area.
Could you just extrapolate on that hint you gave there that it's difficult to rely on people to quarantine? Is this similar to relying on people to self-isolate? Do we have data on both of these?
Well, I think Baroness Harding alluded to, we rely on compliance. We have a consent-based system through the epidemic, which has been extremely powerful. I mean, we have been huge beneficiaries of public goodwill through all of this, and we would never have achieved what we've done if the public hadn't been on our side. But people do get tired, and people who travel are traveling for a reason. They have a high motivation for wishing to leave their home and doing the thing for which they traveled to. And we have to be realistic about those motivations. And until it's proven to me that we have a way of reliably booking people in and making sure that they don't circulate until their quarantine is done, I am extremely sceptical about whether we should be going down that route.
Do we have a measurement for how many people are observing quarantine? Are we trying to follow that up through random checks? Do we have a number?
We are analysing it. If it emerges that we have to do more in that area, then we will develop policy to address it.
Thank you,
Lord Bethell.
Can I thank our witnesses, and in particular Baroness Harding and Lord Bethell, our final witnesses of the day. We do appreciate the immense hard work and the pressure and the stresses and strains of both of your roles. You are giving public service, we recognise that, and public service at a time that is probably unprecedented, certainly in recent decades, in terms of the decisions that have to be made under uncertainty. We're keen to understand why decisions have been taken, principally to be able to reflect on them and to learn lessons, because there will be other decisions that will be that have yet to be taken. One of the themes that we have discovered through our evidence sessions through the pandemic is that there is always something around the corner, and the need to anticipate that has been so common to many of the challenges and many of the policy difficulties that we've had. And so hence the question about the autumn and capacity for the autumn. But following autumn there will be winter, and then there might be positive aspects of anticipation as well. Perhaps if we get a vaccine, if we get treatments, and we manage to wrestle the prevalence to the ground. So that is one of our themes. We're very grateful for the candour that you've given to the committee today. We'll reflect on it and make some recommendations that will be entirely in the spirit of helping you do your work, which is to keep the nation safe and well. Thank you very much indeed. Order, order.
Thank you, Chair.
Thank you, Chair.
Thank you both.
Thank you. Are we off broadcast?
Yes, the only thing is...
Committee Room 6, sound. Committee Room 6, sound. Committee Room 6, sound.